Thank you to Dr. Paula Carter and the other organizers for asking me to give this blessing. I am humbled and honored to do this from Poplar, Montana on this beautiful day on the Fort Peck Reservation, the traditional lands of the Assiniboine and Sioux tribes. Please pray with me in the way that you were taught. Let us pray. Creator, through your divine power and love, I call upon you to be with all of us. We give thanks for bringing us together in health and wellness. We give thanks for this opportunity to learn so that we can be of benefit to the people. We represent your strength and resilience, but we are also pitiful and in need of your help. I ask that you bless each and every one of us. May the presenters be guided by your wisdom as they share their important information. May the listeners hear the knowledge that is meant for them to assist the people. We know you are always with us and continue to protect us. In your name, Creator, amen.
Thank you, Dr. Williamson, for providing that opening blessing. Good morning. I'd like to introduce myself. My name is Alberta Vicente. I am the Health Promotion, Disease Prevention, and Acting Health Education Consultant for IHS headquarters. I will be your host today, and I'll let Lucy introduce herself.
Hi, good morning and good afternoon, everyone. My name is Lucy Canson. I'm the Management Analyst with the Division of Community and Clinical Services. Today, I'll be assisting Alberta technically. So if you guys have any questions or concerns, please feel free to put anything in the chat, or you can chat me directly. Thank you.
Thank you, Lucy. The title of our session today is Town Hall Panel, Breast Cancer Facts, Personal Cancer Journey and Resources. You'll learn how to reduce your risk, understand the importance of early detection, access available resources, recognize potential signs and symptoms, and hear a personal story of recovery. First, I'd like to share that we are offering continuing education units. In order to claim credits for any webinar, participants must be in attendance of its entirety. We did have all the presenters sign a disclosure form. We have a panel of wonderful speakers lined up. If you should have any questions, please submit your questions in the chat box, and I'll read the questions at the end of the presentation. Now I will introduce our panelists. Our first speaker is Dr. Loretta Christensen. She's an enrolled member of the Navajo tribe and serves as the Chief Medical Officer of the Indian Health Service. As the Chief Medical Officer, Dr. Christensen is IHS lead expert on medical and public health topics, giving technical consultation and guidance to the Office of the Director and IHS staff throughout the country on American Indian, Alaska Native healthcare policies and issues. She provides national leadership for clinical and community-based health programs of the agency and serves as the primary liaison and advocate for IHS health professional. Dr. Christensen received her undergraduate degree in biological anthropology from Harvard University and a medical degree from Heinemann University Medical School, now in the Drexel University College of Medicine. She completed her general surgery residency at Monmouth Medical Center in New Jersey and a fellowship in trauma and critical care at Cooper University. Dr. Christensen also holds a Master's of Business Administration from Georgian Fort University and a Master of Jurisprudence with a specialty in healthcare law from Sutton Law School. And our second speaker is Melissa Buffalo. Ms. Buffalo received a Master's of Science in Human Development from South Dakota State University and has over 15 years of experience living in the public health sector in a variety of different roles. She brings a wealth of knowledge to American Indian Cancer Foundation as the Chief Executive Officer. Melissa is committed to working with and for tribal nations and urban and rural tribal communities with opportunities to heal emotionally, historically, spiritually, and physically from the inequities of cancer. Her responsibilities as the CEO of the American Indian Cancer Foundation include the overall direction and implementation of a strategic vision to improve Indigenous cancer outcomes nationally. And our last speaker is Cherie Paris. She is a person who's going through breast cancer recovery, and she will introduce herself when we get to her talk. So now I'll go ahead and turn it over to you, Dr. Christensen.
Thank you so much, Ms. Pacenti. Thank you, Dr. Williamson, for the great prayer this morning. I'm so pleased to be with you, an honor to speak to you today. We are talking about a very serious topic, but I want to say that we're educating, we're sharing information, but the most important thing we want to share today is the possibility of decreasing breast cancer, of surviving it, and of prospering after breast cancer. We want to look at the positive opportunities we have to decrease this all across Indian country. So breast cancer is the second leading cause of cancer death for our American Indian and Alaska Native women. Approximately 1 in 8 women will get breast cancer in their lifetime, which is a lot. The American Indian and Alaska Native women have a 7% higher cancer rate compared to non-Hispanic white population, and a 10% higher death rate compared to the same population. Among American Indian and Alaska Native populations, the important thing is that half of the cancers are screening detectable overall, and 25% of those that are screening detectable are those cancers being of female breast cancer. So we have a unique opportunity to definitely change this. And we're going to talk more about that in each of our presentations today. So breast cancer awareness is all about early screening and prevention. It is a priority for the Indian Health Service, and I know it's a priority across all of Indian country, tribal and urban sites. All patients 40 and older with breast tissue are encouraged to discuss their screening options, and we do encourage those mammograms to start at that time. There is this little no man's land between 40 and 45 years old, but we know our population is stressed. We know our population is at higher risk, and I do recommend starting at the age 40. So we make sure we get in that habit of routine screening and that type of care. So in addition, I want to talk about the things that can help us a little bit. We know the risk factors that make cancer more prominent in American Indian and Alaska Natives, and that is things like obesity, type 2 diabetes, poverty, and a lot of the other challenges that we have. And I would be remiss if I didn't mention our social determinants of health and our health disparities do have a huge impact. And so we look to put our programs to focus on mitigating these things. We have our great new life coach program that's the first cohort's finishing, the new one's going to start. We want to get out into the community and work on more exercise, healthy eating, healthy lifestyle. We want to limit our alcohol intake, and commercial tobacco is a huge contributor to the risk for breast cancer. So just think, if we take all these things together and we work as communities, and I'm talking collaborative communities across Indian country, we can really change what's happening, and we can definitely reduce that risk. We also know that breastfeeding will reduce the risk of breast cancer. And we also know that we have other things that we can do that are helpful. We do run our baby friendly program throughout the IHS, of which we are all certified at this time. We want to do this improvement initiative to increase that breastfeeding initiation and duration. And then we want to always look at being healthy even before having those babies, because we'll have a healthier baby. And we want to work on childhood obesity because we want to break any cycles that are occurring as we move forward, and then put our patient population in the best health possible to address these issues. I hope we'll get to talk more with the question section, but I want to encourage each and every one of you. We can detect this early. We know that in our American Indian, Alaska Native population, we tend to be diagnosed later in the stages of cancers, including breast cancer. But we can do this with screening, We can do this by pushing out in the communities and establishing community public health where we are screening. A great program in Navajo that's working on that with colorectal screening out in the communities. We can add this to it. And I know we can't carry around a mammogram machine, but we do have mobile units. We do have them at most of our facilities, and we can look to expand that as needed. But we encourage each and every one of you to please do this screening and protect yourself, stay healthy and stay safe. So with that, I'm going to give it back to Ms. Pacenti, and I hope to have some good questions after the presentations. Thank you so much.
Thank you, Dr. Christensen. And I'm going to go ahead and go turn it over to Melissa Buffalo.
Thank you, Alberta. Haomidakiapi, Melissa Buffalo, Imachiapie, Michincha Numyunke, Kanji Wakba, Oyanke na, Meskwaki, He Matahan, Bade Ota Otunwe El Wati, Wopilatanka. Hello, relatives. I just introduced myself in Lakota, a language that I was taught growing up in Rapid City, South Dakota. My name is Melissa Buffalo. I am a mother of two. I'm an enrolled member of the Meskwaki Nation in Iowa. I'm also Dakota from the Crow Creek and Lower Brule Sioux tribes in South Dakota, and I live in Minneapolis. I am the Chief Executive Officer with the American Indian Cancer Foundation. I call it ACAF for short, so when I say ACAF, it is the American Indian Cancer Foundation. We love our alphabet soup here. I've been with ACAF for 3.5 years. Again, just want to thank Alberta Pacenti for reaching out to ACAF and allowing me to be here with all of you today, to the panelists as well, and just another thank you to Dr. Williamson for the opening blessing. And Dr. Christensen, I would love to find a way to have a mammomobile go across Indian country. Next slide. Just a quick overview. Dr. Christensen talked a lot about this, but just want to give a quick overview of the American Indian Cancer Foundation, signs and symptoms of breast cancer, talking more about those risk factors. And then how can we, again, review some of that breast cancer prevention efforts? What are those culturally tailored tools and resources that we can use in the community and with our tribal clinics, health systems? I want to talk about Screen Our Circle, which is our national breast and cervical early detection program. We were just refunded for 5 years, and then kind of share some of our culturally tailored resources with you all. Next slide. The American Indian Cancer Foundation is a national nonprofit organization established to address the tremendous cancer inequities faced by American Indians, Alaska Natives, and Native Hawaiians. ACAF was founded in 2009 and became operational in 2011. I love that our footprint continues to expand as a national organization, and with a staff of 22 continuing to do the work we do across Indian country. We strive to be a trusted partner by tribal and urban community members, leaders, healthcare providers, and others working towards effective and sustainable cancer solutions. Our mission is to eliminate cancer burdens on American Indian families through education and improve access to prevention, early detection, treatment, and survivor support. Next slide. Through hard work, that culturally appropriate community-based programming and policy change that affords Native people access to the best prevention and treatment strategies, we really do see a day where American Indian communities are free from the burdens of cancer. Next slide. And again, that approach we take, right? We really believe that our communities have that wisdom to find those solutions to help those health inequities, but oftentimes are seeking that organizational capacity, that expert input, and some of those resources to do so. Next slide. Just a quick overview of the programs we have at the American Indian Cancer Foundation. Our cancer equity team really focuses their efforts on raising awareness of many of those common and screenable cancers. Dr. Christensen talked about that, right? Those screenable, preventable cancers that, early detection is best. So we look at that through some of the cancer awareness campaigns that promote screening. Again, looking at those culturally tailored resources, trainings, and media tools, community education and outreach activities that, are specific to each community we work with. And then again, that collaboration with clinics to help build capacity and improve the tribal health systems to really get our relatives screened for cancer. Our policy and prevention team aims to engage, educate, and empower Native communities to implement those healthy lifestyle practices that again can help reduce some of those cancer risks across Indian country. This team really provides that technical assistance to tribes and Native organizations in developing some of those tribal resolutions and policies that again will, overall help improve some of those health outcomes. And lastly, our research program supports the collection and use of population-specific data, aiming to find culturally relevant health solutions that are both effective and that resonate within our unique communities. We make it a priority to disseminate those findings back to the communities in a way that is useful and beneficial to them. Again, so they can benefit from those ideas and that knowledge, and they can create a sustainable impact and change for their community and their community members. Next slide. So again, Dr. Christian talked a little bit about this. Again, as we think about those signs and symptoms of breast cancer, we really want our relatives to understand what to look for. Again, when you're practicing a self-exam, understanding and learning your body and knowing your body. And again, just, being sure that you're discussing this with your provider or your doctor when you see any of these changes or abnormalities. And as we look at these signs and symptoms, right, we know that no breast is typical. What is your normal may not be another person's normal, even within your own family. So again, things that we highlight at ACAF is really just, to feel empowered and to know your body, so that you are aware of these changes and you're aware of these symptoms. So some of the specifics are, you can go to the next one. We created this resource that really looks at, breasts and what is, some of those signs, change in size or shape. Do you feel a new lump in the breast or your underarm? Is there fluid leaking, inverted nipple, flaking, peeling, scaling, or crusting of the nipple area? Are there new dimples or areas of skin that feel like an orange peel? This is fun conversations and things like, again, we need to normalize these conversations, right? Does your breast look inflamed? Is it red or hot to the touch? Is there a distinct vein growth? And so again, these are signs and symptoms, and really being able to take care and understand your body, I think is really key. And as we think about that early detection and just health promotion within our own bodies. And so this resource here is our Check Your Doo-Doo Shiman, which in Ojibwe means breast. We also have a blank version that we encourage our clinics and others to use to download, and they can provide it back to their community members and also learn breast for their tribal language. Next slide. Again, Dr. C talked a little bit about these. So what are those risk factors related to breast cancer? And these are, some of these we can't change. And again, we know that some of our females will get breast cancer even without any of these risk factors that they know of. And just because you have a risk factor doesn't mean you'll get the disease, and not all risk factors have the same effect. Most women have some risk factors, but also most women do not get breast cancer. Again, Dr. C talked a little bit about those numbers. 1 in 8 American Indian women will be diagnosed with breast cancer. So again, understanding these risk factors, talking to your provider, to your clinic, to lower your risk, and to be encouraged to schedule that mammogram. So again, age, right? Can't change our age. I tell my kids all the time, I'm only 23. Gender being female, breast density. My provider talked to me about that a lot, and I was like, what does that mean? And I've heard other American Indian females that I've talked to talk about that. Genetics, what's that inherited DNA? And then our family history, first degree relative or having multiple family members who have had breast or ovarian cancer as a risk factor. And then again, that personal history. Oftentimes women who have had breast cancer, unfortunately, are more likely to get breast cancer a second time. So again, being aware of your changes in your body is so important. Next slide. So again, what are the, we know the risk, we think about those symptoms. What are some prevention efforts that we as an individual, healthcare providers, community workers, like how can we really bring this conversation and look at some of those prevention efforts? We know that, breastfeeding helps. It reduces that estrogen exposure that helps prevent breast cancer. She talked about weight control, understanding that overweight or obese women are at a higher risk for breast cancer. prevention, scheduling that mammogram, again, encouraging yourself and women that you work with in the community who turn 40 to schedule it, to have that conversation with their provider. Exercising at least 3 times a week may lower your risk. Limit alcohol use. Dr. C mentioned a really good one again, tobacco cessation. And again, I can't stress the need to, again, think about mammograms and how often you need those, and just building a relationship with your healthcare provider to be able to carry on these conversations on a regular basis. Thinking about, does the clinic host any events? Can they host any events to encourage the community to talk about breast cancer, to be able to have opportunities to have communities schedule that mammogram? Next slide. Wanted to share some of the culturally tailored tools and resources that we have available at ACAF through our website. A lot of them are downloadable. Right now we have an Indigenous Pink Pledge, which, again, pledging as a way to get your community, your clients, your patients to pledge to, is this a form that might be a way to encourage them to get screened, or, knowing they can check that box that say they did get screened when they turned 40. So again, please reach out to me. We do have these resources on our website. We can also send out the link. This is a Google form that individuals can fill out, and then we'll send you the form completed and you can print it out. Next slide. We recently created a series of resources for women by age. So I just put 2 of the 5 up here. I think this is age 50 to 65 and then 40 to 49. So again, it doesn't just focus on breast, but all the preventable cancers that are screenable. So it talks about the age and when you should have that conversation with your family and your provider. Next slide. Again, taking into consideration, COVID-19, where the pandemic slowed, if not, came to a complete stop of scheduling mammograms within the clinic. So taking into consideration where we are with the COVID-19 pandemic and, getting back to screenings, and, we hear a lot about, screenings are getting back to normal. I don't know that that was American Indian, Alaska Natives normal, right? We've always been, have a higher rate of late stage diagnosis, like Dr. C talked about. So how can we really, encourage relatives to get screened earlier? Early diagnosis means you have a better chance of survival. And so some of these resources talk about that. They talk about other cancers outside of breast and kind of, what is a way that your clinic and you can, stay healthy while scheduling these events, masking up, sanitizing, scheduling them spaced out. Next slide, please. Right now, ACAF has our Indigenous Pink campaign going on. It's an opportunity to honor our relatives, who've been diagnosed with the cancer, with breast cancer, opportunities to learn, engage, with us for the entire month of October, as we have a social media toolkit. We make it general, so other clinics and communities can use it. Share the resources. That is why, we want them to be out in the community. We want providers, clinics to use them, to share them, to make them adaptable to fit your community. And again, encouraging our loved ones to get screened for cancer. And then lastly, hosting an event. What are some events that you can reach a lot of community members in a small amount of time? Next slide. Wanted to again just kind of end with talking about our CDC funded program. We do have funding for the National Breast and Cervical Early Detection Program. We call our program Screen Our Circle. There are 13 tribal orgs that receive this funding. Every state has this funding. It's an opportunity for these funded programs to reimburse clinics for breast and cervical cancer screenings. As and if there is a diagnostic services for eligible women, we reimburse the clinics. We work with the clinics to get uninsured or underinsured women screened. Again, every state has this. We have 13 tribal orgs that have this funding. Again, and then, we also have funds to reimburse patient navigation. So if you have a clinic that wants to participate, right, reach out to your state, reach out to, we have the link for these 13 tribes that have been funded. You can also reach our staff at screenourcircle@acaf.org. And again, the overview of Screen Our Circle is to increase the cancer screening and early detection rates for Native serving clinics. Again, ultimately reducing the impact of breast and cervical cancer across Indian country. And again, this new cycle of funding provides support to clinics. Ours is specific to the Eastern Indian Health Service region. And again, just removing, how do we work with the clinic to remove some of those barriers and getting women in the clinic to get screened, raising awareness of some of these burdens and, what are solutions that the clinic can use that don't cost a lot of money or don't necessarily need more staff. And again, just promoting that health systems change. And just, one more emphasis again, our Screen Our Circle team is committed to removing cancer screening barriers in every Native community, providing invaluable guidance and leadership to push the needle closer to health equity across Indian country. And I, am positive in saying so do the other 12 programs that are funded that want to work with Indian country or within their community. Next slide. We also have funding for the National Comprehensive Cancer Control Program, which provides funding, guidance, and technical assistance to design and implement impactful, strategic, and sustainable plans to prevent and control cancer in their communities. There are currently 7 tribal orgs that were funded in this new round. Again, looking at primary prevention, early detection, survivorship. What are some of those proven strategies? What is the access to healthcare? What are those policies and programs that work, and how can we make them adaptable to the community, to the clinic? We have a coalition, that meets monthly and quarterly to really, use the Indigenous Cancer Plan. Again, every state has a cancer plan. These 7 tribal orgs all have their own cancer plan specific to our population. So again, if you want more information, feel free to reach out to health@acaf.org. And then I just want to end with sharing some of our other culturally tailored resources. So next slide. Again, we talked about obesity being a risk factor, and a prevention effort is healthy eating. So looking at, what is Indigenous food for your gut, good health. So this is a downloadable version that folks can use in their community, in their clinic. Next slide. Again, looking at another, one related to health and access to food is how do we preserve some of those Indigenous foods in the kitchen? So this just really walks through some of those ways and how we can food, what are foods we can freeze, foods that we've harvested, planted, and grown. And this was created through our policy and prevention team. Next slide. And again, I just want to thank you all for being here today, for hearing all about the risk factors, prevention, again, just encouraging us all to get screened, to stay up to date, to have conversations with our providers. And then the last slide is just, multiple ways to engage and interact with my staff and I. With that, I will hand it back to Alberta. Thank you.
Thank you, Melissa and Dr. Christensen. Our next speaker is actually maybe signing on, so what we'll do now as we're waiting for her is we'll go ahead and go to questions and answers, and then Cherie comes on and we'll go ahead and go turn it over to her. So I do have a question in the Q&A box. It says, is this for only tribal member, or does this also include Native family members? Not sure who that question is directed to.
The reimbursement. So this is for eligible women who want to get screened. Again, this is through the CDC funding. Each state and those tribal orgs have the funding. It's geared towards women who are uninsured or underinsured. I will also let Dr. C chime in if she wants or has additional input.
Well, thank you so much. That's a great question, and I'm going to say it depends. A lot of our tribal communities, we do serve our non-native family members, relatives. Certainly during COVID, treated everyone. because we were all, as with many things, we're all in this together, and we want everyone to be healthy. And many times that is the only healthcare in a community, and therefore there's inclusiveness in those communities. When there is other areas like our urban sites and such, then it is, there's other opportunities, then that's fine. But so it depends on which community we're talking about. But in my mind, I'm sure Melissa, we're just trying to keep everybody healthy, keep them moving forward with their lives without having these type of interruptions of dealing with cancer and things such as that. So our goal is just to make everybody aware and keep everyone healthy.
Great. The next question is, how would we get more information on the mobile units for screening at our clinic?
For us in our areas, I would say that you can talk to your nearest service unit and or the area office, because they do have schedules of when these vans and these mobile units are going to be out in the communities. It varies from area to area, but we certainly encourage it. And I love what Melissa said, because I think I dream of 28-foot trucks every night, either delivering food or taking care out into the communities, or taking mammograms out into the communities. And I'll just take a minute to say, I believe, and I know our new director, Ms. So, believes we take the care where it needs to go. And so we really have to look to getting back out into the communities and going to where our people are and doing as much as we can out in that milieu, because we're not going to get everybody into a facility. We do our best to place our facilities so people can access them, but we know rural and extreme rural areas in Indian country, it is a huge challenge. So I say then, fine, let's take it to the people. And that is what we hope to do moving forward. Ms. Pisani is involved in our new project to really put cancer care out there and get it organized in our communities. We're looking to establish some navigators, a lot of education, a lot of community-based screening. And I'm going to make a pitch for our diverse and innovative workforce, because that's what else I dream about at night, is we're not going to have enough nurses and doctors to be everywhere, but we can train healthcare workers. We can train CHAP, we can train DHATs and BHATs, and our CHRs are fabulous across the agency. They are good people to be out there working with our population. We educate, we train, we support, we back them up with SMEs and warm lines, and we will cover so much more Indian country as we encourage people to be educated. And that may make them even go further. We may be growing new nurses and doctors with these opportunities. So it allows us also to help our American Indian Alaska Native kids get interested in healthcare and public health. And so I think it's a win-win. We diversify our entire workforce. We get to way more people, and we're going to be able to ask those questions culturally appropriate to each tribal community about what Melissa said. How do you talk those words sometimes? How do you explain self-exams and breast cancer and lung cancer and everything? It's because we train people to work within their communities. Then their respective parts of their community are their ones helping. So I am so excited about these opportunities to get out in the community, and I'm still going to go for those 28-foot vans. And I know Melissa will be there helping and cheering at the same time. So thank you so much.
Okay, our next question, it says, good morning. Is the American Indian Cancer Foundation organization producing any Native American specific educational brochures? I can't locate anywhere, and I think this would be greatly increase our efforts to get education to our Native community.
So again, we do our best to either tailor it specific to that community. One of our clinics we partnered with last year was the Oklahoma City Urban Clinic. And so some of those resources, we did patient reminders, postcards, and had their logo on it. Again, use some of their tribal words. We also created blank versions. So if you want to reach out, I definitely encourage you to reach out to us, and I can connect you with our staff to get some of those brochures and, to hear also kind of what specific education if there's a, specific cancer you're looking for, so we can work with you to get that information to your community.
Okay, the next one is a comment regarding the mammal units. It says, for Navajo area, there is a program called Navajo Nation Breast and Cervical Cancer Prevention Program. We established an MOU with the IHS, and the mobile unit comes to the rural clinics who do not have fixed mammal screening. Okay. All right, the next question is for Dr. C. I just recently heard about inflammatory breast cancer. Is the does the mammogram able to detect inflammatory breast cancer?
Well, inflammatory breast cancer, unfortunately, isn't as common as the other cancers, but it is a very aggressive cancer. It is typically seen in physical exam. So this would happen with your self-exam, or the examination by your doctor is going to see the skin changes that are going to occur with that. You still need the mammogram to look for anything else in the breast tissue. But typically you should see signs on the surface, as Melissa showed you with that really great diagram. You're going to see the changes in the skin. You're going to see maybe difference in color. It'll be tougher skin, like that orange peel feeling. It's a little bit thick. So it tends to be very clinical in its presentation, very obvious in its presentation. So not so much picked up on the mammogram, although that will show some thickening of the tissue at the edges where your skin is. So it is something that you can pick up yourself with self-exams, and looking for all those signs of skin changes or nipple changes or leakage from there. Those will tell you, I have to go get seen. Something is not right with my body, and I need to go get seen and examined by my doctor. So thank you for the question.
Okay, the next question is for Melissa. Do you offer any training for how to start a survivor support group?
Oh, that's a really great question. We do have a survivor support group led by our Cancer Equity Program project manager, Misha LaPlante. And I want to say we have a toolkit that kind of talks about how you can set one up in your community. That's an opportunity also to, attend our support group and have that conversation with Misha. Again, we'd love to tailor it to your community and what would work best to create a support group for cancer survivors within your community.
How long is the training, and do you offer it virtually?
We don't have a specific training to create a survivor support group. I think, ACAF has really, in the last 2 years, really delved into and had funding to do some of the survivorship. We just, within the last year, built a survivorship advisory council. And again, right now looking for, is there grant funding to continue this? Because I think the knowledge and wisdom we are hearing from our Indigenous cancer survivors is so valuable to the work that we want to do to create and eliminate to eliminate the cancer burdens. So if you can connect with me, I think that would be best. And we can definitely work with you and kind of hear what some of those needs are and share with some of the work that's been done on our end.
The next question is for Dr. C. We don't hear very much about breast self-exam as we used to before. Is it still recommended?
Yeah, thanks so much for that question. And it is absolutely recommended. As Melissa was saying, no one knows your body better than you, and you would be the one that should be able to see something's different or feel different. And we do absolutely advocate for self-exams, because we do our mammograms, annually up until age about 55, and then it can go biannually unless you have a history of cancer or changes in your breast prior, and then it would probably stay annually. But there's a lot of time in between those, and so what we do is, for ourselves, again, advocating for ourselves to stay healthy, is do that exam all the time, because it's very easy to do. You're going to be the one that's going to say, this is different, it doesn't feel right. And if I'm your doctor and I maybe get to see you once, maybe twice a year, it may not occur to me that it's different for you, because we're seeing hundreds of patients. So it is absolutely, you're the best doctor for yourself in that point. is to do those self-exams. So absolutely, please.
Okay, the next question for you is for Dr. C again. It says, is breast cancer associated with lymphatic cancer, like a lump under the armpit?
Yes, the way breast cancer, as it moves through the stages, you heard us both talk about early diagnosis and how unfortunately in Indian country, we tend to be diagnosed in our later stages. Certainly with breast cancer, some of it is very slow growing, by the way. It can take years and years and years of what we call doubling, which it'll just double cell by cell to get to a size that you can feel. But during that time, the lymphatic system drains the breast of normal debris and things that the lymphatic system cleans up. It's like a big filter. Well, it's going to drain to mostly your armpits or your axilla. And with time, that cancer is going to drain in through that lymphatic, and then you can get a lump also in your axilla. You know, that is a further stage of it. It is certainly still treatable. And we have excellent ways of sampling, which is called a sentinel node biopsy, where they'll take the lump out of your breast and they'll also shoot some dye and see if your lymph nodes light up. And they take the sentinel node and they test it to see if it has metastasized or moved from the main tumor into your lymphatic system. And then your treatment is tailored accordingly. So yes, it can definitely, and it also on the inner parts of your breast, it can drain into your chest wall lymph nodes as well. So that's the filter for the breast, is the lymphatic system. Thank you.
Okay, thank you. We still don't have Cherie, who hasn't signed on. I guess she may having difficulties, so please keep the questions coming. Please put the questions in the Q&A box if you have any question.
While we're waiting, Alberta, I do want to just give a shout out to ACAF. I follow their Facebook every day, and I encourage you to do that too, because there's really great information on their Facebook page that is very educational, very culturally appropriate, and they just, you know, great team that they have there, and that's another way to kind of hear the latest stuff. You know, we love to post a lot on our website, and we're working on expanding that, which is more patient centered, because we want you to also go to our website and do that, but we're not quite where they are. So I do encourage you, and I just want to give a shout out to her and her team for the excellent work that they do on there. And I think this brings us to, again, I want to bring up collaboration. And I think, you know, I absolutely know it's a priority of our new director, Ms. So, is that everything is collaborative. You know, everything should be done together with tribal organizations, with urban, with these foundations that have great teams, great ideas, great media and graphics that really show people what we're looking at. And we all want to work together. That's why I'm so excited that Melissa's on this call today, because it's a way that we communicate with each other, and it's a way we enhance the work that we do. What we bring to the table. We're not in competition. There's no adversarial issues here. We're all for the people. We're all for our people, and we're all for making them healthy. So I just want you to know, as we move forward with our cancer initiative, we want to include all of the coalitions at the table. So all the strengths that we have in Indian country are put to the best use, and a synergy is created amongst all of us to give the absolute best care to all of our people. So I just want to take a moment to say that, because I think this is very vitally important as we move forward.
Oh, thank you, Dr. C. That was amazing. I love the work that our staff do. And again, I think I'm always stressing to my staff that, you know, we're a team of 22. We can't be everywhere. And the work that we know our communities and our clinics are doing, right? That collaboration can only be strengthened in reaching our communities and eliminating cancer burdens and, you know, diagnosing early cancer, because it is treatable when you diagnose earlier. So again, I love the shout out on the collaboration.
Hey, there's a question that came in. Thank you, Melissa and Dr. C. It says the U.S. Does the IHS still stand by the U.S. Preventive Services Task Force recommendation that women who are 50 to 74 years old and those who are at average risk for breast cancer get a mammogram every 2 years? And women who are 40 to 49 years old should talk to their doctor or other healthcare provider about when to start and how often to get a mammogram.
Well, that's a fair question. I'm going to give a slightly complicated answer. We do look at the guidelines for sure, but one of the things I have discovered working with my great chief clinical consultants across the agency is that we feel we have to come forth with our own recommendations that are consistent for Indian country. So we are working on that. We feel there's still more opportunity for additional screening for all cancers, not just breast cancer. And so we would like to put forth kind of what we see for our American Indian Alaska Native population. And I do recommend 40 starting those screening exams, because just remember all the risk factors. You know, we're dealing with high BMI or obesity issues. We're dealing with, as Melissa said, the estrogen continuously showering our system increases risk. So, you know, and we know that it is also to deal with how old you are when you have your first child, if you have a child. So we just know in our population, there is much more jeopardy of having breast cancer than the guidelines that are generally put out for the general population. And this is an interesting connection to equity, because equity is kind of like we all start at the same place and we all can go forward. And we know we're not at the same place because we're still building infrastructure. We're still dealing with, the old colonization issues, the historical trauma, all the things that we are challenged with. And then I'm going to add in there just even the historical trauma. It requires the trauma-informed care approach, because that constant stress also makes you very vulnerable to cancers and disease. So I'm going to advocate on trying to capture the most people that we can that are at risk as soon as we can. Now, there's some that may need to be screened before 40. It depends what the family history is. It depends their environmental factors. It depends on their overall health. But certainly by 40, we should be in that habit. And as I kind of mentioned earlier in my talk, when we get to that 55 range, if you have no risk factors, if you've been very healthy, you could consider biannual type of exam, mammogram exam. But if there's any history and still these risk factors that I think are so impactful, then we decide to do it annually. So there's not one fits all for every single person, but I think as a population, I'm going to always err on the safest side of trying to have early detection. So I hope that answered your question. And when are we going to get these out? I hope soon. And we're going to do each specialty, because I have an expert in each specialty that's going to give me feedback on what we think is safest for our population. And we certainly want your feedback. And we're going to try to refine that. So thanks for a great question.
Okay, the next question is again for you, Dr. C. Does having hydrodenatist I don't know.
I got it. Hidradenitis suppurativa. No, it is not particularly directly related to breast cancer. It is an unfortunate condition that some people are challenged with. It can affect, of course, the drainage into your axilla or armpit, as we call it. But in and of itself, it is more of an inflammatory type of thing in the region of lymph nodes and the way the cells drain into your system. So no.
Okay, the next question is the American Cancer Society, the U.S. Preventive Services Task Force, and other organizations have different recommendations for this different cancer type. Does IHS plan to develop a standard recommendation for American Indian Alaska Native population to avoid the confusion?
Yes. I mean, it seems very straightforward, and and great question again. But there is a lot of complexity in trying to refine down all the research, all the studies, and all the recommendations. But when you have a higher number of cancers and you have a higher number of deaths from those cancers, I think that is not what's factored in some of the time. When recommendations are made for the general population, they're taking the norm of the population and they're doing recommendations for the majority of that average American. We're not average in any way, and that means a good thing too. We have special talents, special culture, special things that we do, but we also have special vulnerabilities that we have to deal with. So yes, it will be tailored to our population as best as we can cover every one of these diseases and cancers, yes.
All right, the next question is both for Melissa and Dr. C. Do either organization or agency work with the Roswell Park Comprehensive Cancer for American Indian, Alaska Native? If so, what are some of the work that are you're working on? If not, is there any plans to work with the Roswell Cancer Center?
I can go first. Yes, we are hopefully partnering with Roswell and Dr. Herring on our new funding with CDC. I think a lot of us do some of the similar work. So again, like how are we, sharing shared resources, creating new ones so we're not duplicating, so we know that the information is out there. We are leaning on Roswell, again, as a small organization, what is some of the services they have that ACAF doesn't have. So excited to partner with them with our breast and cervical and our comprehensive cancer. Yeah.
For IHS, we do have an agreement with Roswell. Certainly take advantage of it in the area in which it's located, but it is for the whole agency. We work in terms of care, research opportunities, and also programs that give opportunities to our American Indian Alaska Native kids to get into the STEM medicine type of fields of research and biomedical and such as that. So we have a great relationship with them and have worked on some very excellent projects over time. As I said, it's mostly in the Nashville, what we call our Nashville area, but we're hoping to leverage that for other parts of the country and have those opportunities available to all of our areas. We're actually working very hard, and I know Mr. Woodis was on the call. I hope he's still on. He's been working very hard for us to make connections with other cancer centers in each region, because we want to provide that connection for our population, including Mayo Clinic and MD Anderson and other cancer centers that are close to our areas that we can partner up with. And create agreements with them. We try to, have meetings with them. We advocate for our population. A lot of them do have tribal offices, and it's really great to meet them. And they do really help our patients navigate those really big systems. One of the other ways we're addressing this is that we are trying, I made an ask to the academic medical centers to help us regionalize our care by sending providers to us, so that they're on our reservation and tribal community land. And the patients, may have to still travel a little, but they're not flying 2 states away. They're coming to a center of their tribal communities to have regular appointments with their providers coming to us. So I'm trying to negotiate that through a national type of approach, so that we can have these regional hubs and then keep our people closer to home. We know they do better. It's very hard to send them to what I call the big granite buildings in the cities. They're lost. No one speaks the language. They don't really understand our cultures. And I think the better we can bring the care to the regions and to our communities, I think we'll get people diagnosed, get them to stay in treatment, and then we can do as the survivorship. And then the other thing that we work very hard on is trying to do caregiver training and respite and support, because our families in Indian country do most of the care, but with what? So that is another thing we are tackling, is that we're trying to look at how do we support our caregivers from our families. And one of those, and I'm going to advocate for this right now, that family has to be at meetings with the doctors so that the family understands what needs to be done. Because we lose people in treatment. We all know that. It's hard, it's confusing, it's far away. And that's why navigators and or other programs that are coming forth, another program out of Navajo, Lieutenant Damon is looking at public health aides. Can these people go out and meet with the patients and work with screening, work with, are you on target with things? We want to put all these aides out there to really go out and communicate with people and make sure they're on board, make sure they're okay, make sure they get their labs drawn. We have a wonderful opportunity to create those connections. And I think this will be a valuable part of our health system to do this type of staffing. So I hope that answers your question and probably gave you more information than you needed, but I'm very excited about these projects and I just love to share with everybody what we'd like to do moving forward.
Wonderful. That sounds good. Another question is, patients within IHS typically have challenges accessing reconstruction and radiation therapy for breast cancer treatment. What is IHS doing to improve access to these services?
Well, two things. Thanks for the question. I've always been an advocate of immediate reconstruction and such for functionality, for self-esteem and self-image issues, and really for health of what a surgery was done. It is a good way to do that surgery. Having been in private sector a long time, and I personally had 31 residents that I trained that are all plastic surgeons now. So I'm gonna ask for something back from them now. We're just redoing our PRC priorities. We're almost ready to issue, and we did include appropriate reconstructive services as a priority in our coverage for purchase referred care. So we did expand that because that is state of the art. That is care that everyone should have, and certainly our population should have that care. Secondly, again, with the regionalization, there's a lot of organizations in orthopedics, plastic surgery, and specialties like that that will come and do regional work. We just need to be coordinated in getting them set up a place to see patients. And they do come. We've had hand surgeons come in and do 2 weeks of hand surgery. We do want these specialties for our patients, and we want to do it at our facilities again, so they're close to home. And so I do see expansion of that specialty care for reconstructive surgery. Important not only for breast cancer, but it's important for some of the facial work that needs to be done, for functional eating and kids having the ability to go to school and feel good, about themselves. So we got some work to do, but there are some great options out there to regionalize a lot of this care from our academic medical centers. Thank you.
Oh, you're muted, Alberta.
Sorry about that. There's another comment. It says, during a BCA event we held, we were told that breast self-exams were no longer recommended. Is this true? I think you covered it, Dr. C, but you may want to go address it again.
Well, I can't account for what is said sometimes, but I still completely support it, and I encourage you to do that. Again, your body, you know it best. You're your best advocate.
Okay, we're close to the hour, so thank you so much, Melissa and Dr. C. This was really, and thank you for all your questions, folks on the call, and thank you for joining this webinar. This webinar is being recorded, so you'll be able to access it at a later time and be able to view it. And there was a lot of great information that was shared, and I know that Dr. C and Melissa are very busy, so thank you again for your time and be able to go address a lot of these questions that were filtered in from our folks on the call. And I just wanted to say that for the evaluation, please go to SurveyMonkey to complete your evaluation if you want continuing education units. Once you complete your evaluation, then it will actually print your certificate. So please, this is going to remain open through November the 9th. So we definitely want your feedback on this regarding this webinar. And thanks again, Dr. Christensen and Melissa, and thanks again, everybody. And you all have a wonderful day.